Good evening, friends. I am Dr. Manivasagam from Tiruchirappalli, Tamil Nadu, cardiologist. Before we start this session, I should thank the organizing secretary, Mr. Rahul Mekotra, and Professor Colonel Parashar for having given me the opportunity. Before proceeding to the talk proper, I should introduce this subject and subsequently Dr. J C Mohan for these proceedings. And all the diseases, most of the cardiac diseases and risk factors like hypertension and diabetes, atherosclerotic coronary artery disease, and family history of dilated cardiomyopathy or cardiomyopathy, all these things, they initially trigger the neurohumoral responses to protect the heart from the insult. Subsequently, the same neurohumoral mediators adversely affect the heart and produce detrimental effect over the myocardium to produce the molecular and structural changes in the myocardium. After a few years of lag period, that is called latent period, the structural heart disease remains asymptomatic, and say for example 5 to 10 years of lag period, depending upon the disease character and severity and duration, approximately 5 to 10 years elapse. Subsequently, the patient develops hemodynamic deterioration in the form of fall in ejection fraction and clinical presentation of the disease proper, from occult disease to the overt disease. The disease process starts. By the time we realize that the ejection fraction has fallen, the disease process might have crossed 50 to 60% of its journey. Currently, we are living in the era where people want to identify the disease process quite early, that is in the preclinical stage itself, so that they can prevent the occurrence of the disease and retard the progression of the disease. This is possible only by myocardial imaging, not by the conventional echo. The myocardial imaging starts with the tissue Doppler imaging. As you all know, the S prime of tissue Doppler imaging denotes systolic function. E prime and A prime denotes diastolic function. We know pretty well that tissue Doppler has got its own limitations like angle dependency, tethering, and so on and so forth. To overcome these limitations, we have come out with Speckle Tracking technology derived 2D strain imaging. So currently throughout the world, in the field of echocardiography, 2D strain is the only method available to identify subclinical LV dysfunction. That means we can identify the disease in the latent period itself. To talk about this 2D strain, how to perform this 2D strain, and why we should perform, and its application in the day-to-day clinical practice, we have with us Professor J C Mohan, and his contribution to the field of Indian Academy of Echocardiography and the Cardiological Society of India is outstanding. Currently, he is the chairman of Institute of Heart and Vascular Disease, Jaipur Golden Hospital, New Delhi, Consultant Emeritus Fortis Hospital, Shalimar Bagh. To his credit, he has over 300 indexed publications, 2 books, and 76 book chapters. He is a professor of cardiology, GB Pant Postgraduate Institute of Education, past president of Indian Academy of Echocardiography and Cardiological Society of India, and currently he is the president of Apex Society for CME in Cardiology. With this brief introduction, I will hand over the mic, and J C Mohan, the floor is yours. Over to you.
Thank you, Dr. Manivasagam. Good day, ladies and gentlemen. Welcome to this IAE webinar on how and why to measure LV myocardial strain in daily clinical practice. 2019 appropriateness criteria suggested by ACC/AHA and jointly endorsed by American Society of Echocardiography suggest that strain imaging is an appropriate technique for diagnosis of cardiovascular disease. Out of a total score of 9 for all cardiovascular diseases, strain imaging scores 6 points, indicating that it is indicated in most diseases of cardiovascular system. Strain imaging in clinical practice is used for diagnosis, establishing etiology, prognosis, treatment, follow-up, device management, and of course, studying the reverse remodeling in patients with heart failure. So in this presentation, I will take you through the background of myocardial strain imaging, methodology, and clinical applications. Galileo, half a millennium back, said, measure what is measurable and make measurable what is not so. So with regard to heart function, initially we started measuring what we call cavity-based measurements, like fractional shortening, fractional area change, and ejection fraction. Soon we moved on to myocardial-based measurements in the form of tissue velocity imaging, mid-wall circumferential shortening, and now, of course, strain imaging. And of course, future belongs to combination measurements, which means we will be combining parameters of myocardial as well as cavity-based measurements. Heart is an active, non-linear, anisotropic, non-homogeneous, viscoelastic material with a definite 3D syncytial geometry, which is in constant motion. And motion is life. We were measuring, as I said, cavity. Cavity is kinematically linked to myocardium. And now we have moved to measuring the parameters of myocardium. But fundamental indices of motion are displacement and velocity. These, of course, can be active or passive. And the third important index of motion, deformation, which is an index of active motion. And we use all these three indices for assessing cardiac function. So the difference between displacement versus deformation, both of which are types of motion, is that there is active contraction and relaxation for which we need deformation imaging, while tethering effect and translation also produce displacement, but it is a passive motion. Deformation is the only intrinsic mechanical property of the myocardium, and hence we should be ideally measuring deformation when we want to assess ventricular function or atrial function. So we were talking about motion, and we said there can be passive motion or active motion. Major vectors of motion and deformation are longitudinal, radial, tangential, and rotational. And the final product, as with regard to atrial or ventricular function, is a cohesive motion of all these four, in all these four vectors. So cohesive and sequential integration of vectors of forces generated in all these four ways ensures mechanical efficiency by optimal deformation. So first thing which we have said so far is that cardiac function is a complex process of 3D myocardial deformation. So what is deformation? Deformation is an alteration in geometry with the application of force. Let us say this cube represents a myocyte, and when we apply force in systole, the myocyte undergoes change in geometry, and the change produced is what is called as strain. The cartoons on the left side are showing you when you apply force, how the shape of this cube changes in 3 dimensions. In fact, the strain are of 9 types, but normal strains are those which are perpendicular to applied force, and shear strains are those which are parallel to applied force. There are 6 different types of shear strain. We don't talk of shear strain in cardiology at the moment. We only talk of normal strains. So let us talk about longitudinal strain. A deformation produced in longitudinal direction of the heart, not of the cardiomyocyte, but of the heart, is called longitudinal strain or longitudinal deformation. This cartoon shows you that when you look at the length of the left ventricle, for example, here, and the cartoon also shows you a cardiomyocyte, from systole to diastole it lengthens. In other words, from diastole to systole it shortens. The shortened amount is delta L. Delta L divided by original length is the strain. And since it is shortening, it is a negative figure, and hence you will describe it as a dimensionless index in units in minus form when we talk of longitudinal strain. The reverse is true for radial strain or thickening strain or transverse strain. Here, let's say cardiomyocyte, or for that matter, left ventricle muscle itself, from diastole to systole as you move, it thickens in radial direction. And this delta T or thickness increase in systole divided by original thickness in diastole gives you what we call a radial strain. And since it is a positive thing, thickening is happening, radial strain would be positive. The third type of strain is circumferential strain, which essentially means that the circumference of a structure, and here we have shown a cartoon of the left ventricle in diastole on the left side, in systole on the right side, and you would see that the round thing shown at the top base is the circumference, and circumference changes from diastole, it shortens in systole. So it is a negative circumferential strain, and this also is one of the parameters which we assess for assessing cardiac function. The fourth parameter is angular strain, or let's call it rotation, or also called twist or torsion. So normally the left ventricular base rotates clockwise when you see from the foot side, but the left ventricle apex rotates counterclockwise from diastole to systole. The difference in the two angles is called twist or torsion. To be called torsion exactly, you have to, numerator has to be the angle difference and the denominator has to be the length of the left ventricle in diastole. But when you only call it an angular motion, you can just mention the angle per se without correcting it against the length of the left ventricle. So let us show you a high definition image of the mid wall, or rather more close to the base of the apex, and this is upside down. And you can see that there is not only circumferential shortening during systole happening, but you can also see the angular motion happening. There is rotational motion of this left ventricular donut, in systole, and it is being restored in diastole. And you can also see circumferential shortening. These are the two latter parameters which we have discussed. There is another thing which people in physics use, and I think we should introduce that subject, and that is there are two types of normal strains, Lagrangian strain and Eulerian strain. A Lagrangian strain is change in length divided by original length, and original length we normally colloquially take as end diastolic length. So most of the parameters which we report is Lagrangian strain, because that is by acoustic Speckle tracking. However, Eulerian strain or natural strain is strain divided by the instantaneous length, and that can be derived by Doppler method, but we don't report Eulerian strain, and we are in clinical practice only using Lagrangian strain. So let's talk a little bit more about physics of the strain imaging. Myocardium follows Hooke's law to some extent. Hooke's law says that forces and deformation are linked by elasticity of the subject. More elastic an object is, more it will be deformed by given force. And the myocardium is viscoelastic, which means it has a drag. When you apply force, it takes time to change itself. That time is because there is a viscosity involved. But what changes elasticity? The elasticity of the myocardium can be changed by the myocytic change in macro or micromolecular structure of the myocardium, extracellular volume, fibrosis, ischemia, and so on and so forth. So the Hooke's law is simple. Myocardial force and strain are balanced by elasticity. And myocardial viscoelasticity is affected by myofiber architecture, fibrosis, edema, inflammation, ischemia, and these all will reduce the elasticity. Hence, for a given applied myocardial force, strain produced would be less. And that is the whole basis of strain imaging as a technique to detect subclinical disease. What changes myoelasticity I have already discussed with you, and Dr. Mani took you through this fact that change occurs as a result of multiple factors, including neurohumoral activation. Finally, what happens is myocytes change in geometry, extracellular matrix comes up, edema, inflammation, capillary rarefaction, fibrosis may come up. And when finally fibrosis takes place, that is quite late. And while ejection fraction is decreased when myocardium involvement is 50% or more, the strain imaging picks up disease when myocardium involvement just falls below 80%. So we actually detect preclinical or subclinical disease by strain imaging. So another cartoon to show you the same thing. Move from left to right. Left is the normal. Strain would be normal because there is a certain amount of extracellular volume or extracellular fraction. With disease process like diabetes, hypertension, ischemic heart disease, multiple inflammatory disorders, there is some degree of reactive fibrosis. You call it expansion of extracellular volume. Here the strain would fall, but the ejection fraction would remain same. And at the ends of the spectrum, you see not only reactive fibrosis, but also replacement fibrosis. And there, strain is already significantly less, although conventional functional parameters have now started decreasing to some extent. So by and large, we would be talking about left ventricle and left ventricle strain imaging. So a little knowledge about the left ventricle myoarchitecture is in order. Left ventricle is involved in cyclical suction and ejection. It is a non-Newtonian, almost synchronous bidirectional generator of force So it is a bidirectional pump. It sucks and ejects. And it has a peculiar geometry. The geometry is that it has fiber arrangement, which is in the shape of figure of 8. There are subendocardial descending right-handed helix fibers, and there are ascending left-handed ascending fibers in subepicardial region. The final thing is that this figure of 8 looks something like this. This is a cartoon drawn by me. Subendocardial region shows descending fibers, which are the ones affected earliest in disease process. And whenever descending fibers are involved, the compensation comes from subepicardial ascending fibers to maintain ejection fraction. But the combination of the two actually is responsible for suction and ejection. So we have subendocardial fibers, which are descending fibers, and we have subepicardial fibers, which are ascending fibers. So this is how the change takes place from diastole to systole, and part of the subepicardial fibers become radial fibers, and most superficial ones remain oblique and produce circumferential strain. So here, this cartoon again shows you the same thing. Endocardial fibers are responsible for sublongitudinal shortening. Mid-wall and subepicardial is through the circumferential. Mid-wall shortening is also through subepicardial fibers and produces radial shortening. Longitudinal deformation, as I said, is dependent on subendocardial muscle bundles, and it contributes 1/3 of the total ejection fraction. And that is one of the reasons why longitudinal strain may be significantly reduced, and hence ejection fraction may not be affected too much. It may just be going down minimally because the contribution of subendocardial muscle fibers to ejection fraction is only 1/3. These circumferential fibers contribute 2/3 of to the ejection fraction. Hence, when there is involvement of the circumferential fibers, the ejection fraction falls. So if you want to pick up the preclinical or subclinical disease, you would have to rely on longitudinal strain, which is dependent in turn on longitudinal subendocardial fibers, which are the ones which are earliest affected by the disease process. So these are the normal values given by the European Association of Cardiovascular Imaging. A longitudinal strain in the ballpark of 20%, to which ASC also agrees. Circumferential strain 20 to 25%. ASC gives slightly higher figures of 25 to 30%. Radial strain 40 plus or more, and twist or rotation 10 degree or more. These are the ballparks. Actually, for every single age decade and also every ethnic group, we need to establish our own values. We have recently published in International Journal of Cardiovascular Imaging the normal longitudinal strain values of Indians in about 1,000 patients and 1,000 healthy subjects, and you can look at that. We also have data from Europe and of course from Korea and Japan, and the figures are almost close to these figures. The premise of strain, as I said, is that some vectors of deformation run ahead of change in displacement, and these are longitudinal vectors and are differential with regard to phase of cardiac cycle, and these provide incremental information, not only about subclinical disease, but also about regional function. An important thing about premise of strain imaging is that not only there is incremental information, it is more reproducible than cavity-based measurements. And let me just show you a cartoon to buttress the point which I'm trying to make. On left, this is a 23 years female who has joint pains, and essentially she was found to have lupus. Now, if you look at her left ventricle ejection fraction, left ventricle volumes on left side, you would find that everything seems all right actually. 56% ejection fraction is not bad. Look at the same by global longitudinal strain on right side, and it is 14%. As you'll recall, The toolbox says that you should be in the ballpark of 20%. So it is already less by 30%, although ejection fraction is within the normal limits. That is the premise of strain imaging in detecting preclinical disease in a diverse clinical situations. So how do we assess strain? How do we do strain imaging? One can use tissue velocity imaging. One can do what you call acoustic speckle tracking, by which you can have 2D or 3D speckle tracking, velocity vector imaging, which is a slight modification of acoustic speckle tracking, MRI and CT. These are 5 different ways strain imaging can be done. The strain by cardiac MR is actually the gold standard because it's more reproducible, and more people now are buying buying CMR machines providing strain. There are 3 different ways MRI can provide, cardiac MR can provide strain: tagged MRI, dense, which is displacement encoding with stimulated echoes, and feature tracking. We wouldn't go in those details. Maybe some other time we will talk about these. The tissue velocity imaging strain was the one which was initially introduced in late 90s, and it was dependent on velocity gradient imaging. At the 2 ends of the sample volume which you placed on the myocardium, one could get the velocity difference and divide by the length of the sample volume to get strain rate. And when multiplied by the time, that would give you strain. So this was the whole premise of strain rate imaging and strain imaging by tissue velocity imaging. And we were at the forefront of using this tissue velocity imaging back in early 2001, 2002. And we did a lot of cases, but we also realized the limitations. But these are some of the examples which we had actually at that time for both strain imaging and strain rate imaging. Typically, this is how a strain curve of basal septum looks like in a patient. So you have ECG at the bottom, and you have a curve of this length of 12 millimeter sample volume. And here, the peak strain is something closer to minus 14%, which obviously is reduced. So this is a original strain which is reduced. But there are components of strain image or strain curve which are important. There is an early systolic stretch, you can see just in the beginning of systole, and of course there is strain appearing after the aortic valve closure, and we call it post-systolic strain. These things are of great importance in understanding myocardial physiology, but for want of time today, we wouldn't be discussing these in great detail. The strain rate imaging was another thing which we used extensively in early 20s for stress testing, but it is now hardly ever used, and I will tell you the reasons. But this is actually a 3-beat strain rate, and you can see the systolic strain of closer to about 2.8, which is, or 2.5, and of course diastolic strain of about 6 per second. Remember, this is how these used to be described. The strain rate is still valuable, but largely in clinical practice, we give dimensionless strain indices and rather than strain rate imaging. So, and the big advantage of tissue velocity imaging was that you could use the color Doppler myocardial imaging, and at a very fine resolution, you could find out what are the areas where strain is less or strain rate is less. And this is an example of the interventricular septum. And you can see that this area, which is green or blue, shows no strain rate, and which actually means that this is a disease area. This is a patient of hypertrophic cardiomyopathy. And of course, the middle part of the septum is diseased. And you also see post-systolic strain here. Why did we give up the tissue velocity strain imaging? Well, there was a good amount of noise. There was a large amount of inter and intra-observer variability. It was a cumbersome technique, of course, angle dependent, as the chairman said. Only longitudinal strain could be studied, needed very high frame rates. Smoothing algorithms were needed because there was a lot of noise, and smoothing algorithms for various vendors were so different that the values would change remarkably, and there were no large outcome data. So we were looking for strain imaging, but tissue velocity imaging had caveats and drawbacks. So to overcome these pitfalls, we moved on to what is called acoustic speckle tracking. So what is a speckle? What is a speckle tracking? So here is actually a contrast imaging in a patient of hypertrophic cardiomyopathy, and in the box is the basal anterior septum. And within that myocardium, you can see some white dots. These are speckles. Speckles are natural echo reflectors when these are acted upon by ultrasonic waves. When ultrasonic waves interact with natural reflectors, there is reflection, backscatter, and refraction. And the end result is you see these bright spots, and these are called speckles. We also realize one great thing about speckles is the speckle pattern is relatively stable, at least from one frame to the next. And in post-processing, these can be tracked consecutively frame to frame and ultimately resolved into angle-independent 2-dimensional and 3-dimensional strain-based sequences. How did we do it? Well, it is simple. You do a block matching. You see a speckle at one place, and then you see how does it move from diastole systole or one part of cardiac cycle to another part of cardiac cycle, in how many directions, and all those directions, you depending on the time taken and the length covered in different directions, you can measure longitudinal strain, radial strain, and circumferential strain. So it is terribly simple way of detecting strain in a post-processing algorithm. So speckle tracking starts with generating a velocity field, but this velocity field is angle independent by measuring the speckle displacement and dividing by inverse of the frame rate. This velocity field is then used to calculate the strain rate by spatial deviation, and you can calculate strain by temporal integration. That means multiplying by time. That exactly is the fundamental basis of strain imaging. The velocity vector imaging actually was initially started by Acoustic and then taken up by Siemens. It is based on myocardial feature tracking, which incorporates speckle and endocardial border tracking, as shown your left side. So not only it tracks the speckles, it also tracks the endocardium. So essentially, it was essentially true for much more true for longitudinal imaging, but it also became quite acceptable and robust for radial and circumferential strain subsequently. So we have certain lessons from the acoustic speckle tracking, and that is all strain vectors helped us understand cardiac mechanics in health and disease. We understood compensating mechanisms in subclinical disease. As the longitudinal strain goes down, the circumferential strain increases, angular rotation increases to compensate to maintain ejection fraction. We also realized that global circumferential strain and global longitudinal radial strain did not provide incremental clinical utility. These helped us a lot in understanding cardiac physiology. But as far as clinical applications are concerned, circumferential and radial strains haven't provided any great incremental value. Longitudinal strain proved to be of prime time use because of its early involvement, robustness, reproducibility, standardization, and incremental value. We also learned few things. The longitudinal strain has a base to apex progressive gradient. As you move from base to apex, the regional strain increases. We also learned one thing, that longitudinal strain has an endo to epicardial regressive gradient. As you move from endocardium to epicardium, the strain decreases. So don't go to the pericardium, because there the strain will be markedly low and you will be mistakenly assessing reduced longitudinal strain. How do we do it? Well, it is simple. It has been standardized by the ESCV and ASC task force. Nowadays, of course, most of the machines are giving it automatic. All you have to do is find out 3 points. And of course, then the area is covered by these 3 points. And here in left ventricle, it is medial mitral annulus, lateral mitral annulus, and of course, the inside of the apex. What are the caveats? What are the necessities? Necessities are you should have good quality apical images. Frame rate should be 50 to 80. Region of interest should be from inside of endocardium to epicardium. Avoid pericardium. Positioning of mid-myocardial layer should be accurate. Sequence, of course, for getting in bullseye map should be apical long axis, 4-chamber, and then 2-chamber, and starting point just above the annulus and not on the annulus or on atrial side, because you'll get very different results otherwise. Check tracking quality manually. Measure peak strain and not the end systolic strain. That is what the guidelines suggest. And as I said, bullseye map for average sum strain. For radial circumferential strain, those of you who are interested in understanding cardiac physiology more, you need short axis views at base, mid, and apical levels. And of course, the tracing is done in a similar fashion. So what did I say so far? What was that voodoo or black magic? All I said was, there should be optimal image quality, study wall motion carefully, optimal region of interest, care about annulus and apex, and avoid confusing structures like papillae muscles and trabeculations. Shouldn't be actually including them in the region of interest because these would give very different values. What about of course, the longitudinal strain we also use for right ventricle function. The right ventricle longitudinal strain, you should obtain a right ventricle focus 4-chamber view, which you obtain by transducer position moving lateral to the conventional 4-chamber view. Other things are same. Check tracking quality, region of interest about 5 millimeter. Don't include tricuspid annulus or pericardium, and average of 3 segments of free wall strain is what we are interested in. The latest guidelines for quantification cardiac cavity suggests an abnormal cutoff value for longitudinal RV free wall strain of 20% or less. And for the global longitudinal strain, I had already told you for left ventricle, it is 20% or less. The data to suggest that maybe even higher thresholds could be used for assessing right ventricle function. And quoted right at the bottom is this study from China suggesting that 23% is below 23% is a bad prognostic marker in COVID patients. Interesting data are being generated with the help of strain imaging. Recently, actually, the strain imaging was used for heart failure, for RV strain imaging, and you see on the extreme right that the best value for prognosis was given by Speckle Tracking cause-induced right ventricle global longitudinal strain with regard to prognosis in heart failure with reduced ejection fraction. Some of the vendors have come out with 4D strain methodology, which is a much simpler thing, which gives you strain in all directions just from a single full volume image. You have a full volume image at 30 frames per second. You do volume quantification followed by 4D strain, and it automatically gives you longitudinal strain, radial strain, circumferential strain, and another additional area strain. And area strain has been shown to have some greater incremental value. Time doesn't permit me to go through the area strain part, but we could discuss that later on. And these values obtained by 4D strain are a little lower than 2D strain because these are more end systolic rather than peak strain. Anyhow, they have a good correlation. We actually did some study and presented to show good correlation between 4D strain and 2D strain in 100 consecutive patients with a variety of cardiac diseases. One of the important things which we have realized is that the left atrial function can be studied by longitudinal strain, and this is based on the fact that the ventricular and atrial strains are coupled in disease. If the left ventricle strain is 20% normal, the left atrial normal strain should be 40%. Forget about minus and plus. This is because the volume of left atrium is half of the volume of left ventricle. And essentially, strain is only telling you volume displacement by the myocardium. So 40% is the ballpark for LA strain, the reservoir strain, and 20% for left ventricle. However, there are conditions where there is uncoupling of atrial ventricle strain, and those are the conditions where atrial strain provides much more incremental value in a disease process compared to LV longitudinal strain. So how does left atrial longitudinal strain look like? This is a spectrum. You have in the ventricle systole reservoir strain. Then you have conduit strain in the early part of the diastole and mid-diastole, and later on when atrium contracts, the booster strain. The booster strains are typically around 12%, reservoir strain is typically around 40%, and a conduit strain is about 8-9%. Left atrial longitudinal strain, there are methodology. Actually, recently, of course, as late as 6 months back, the EACVI gave actually method to assess left atrial longitudinal strain. You have to have average of LA focus 4-chamber and 2-chamber strain. The region of interest thickness has to be 3 millimeter. Endo or mid-wall strain in LA is same. It lacks standardization. We have to keep in mind this thing. We still don't have standardization. Challenge is because of thin walls and intra-atrial septum mobility, arbitrary extrapolation of left atrial appendage and pulmonary veins, and suboptimal image quantity because the images are in far field. The purpose is in prognosis and heart failure and mark infarction, assessing filling pressure, diastolic function, valvular heart disease, predicting atrial fibrillation, and conversion following cardioversion. These are some of the things in which longitudinal strain is being used. And I have already taken you through the method of getting left atrial strain. There are caveats, there are precautions for acquisition shown on the top 4, and there are for post-processing 4 caveats or tricks given at the bottom. Essentially, these are very similar to what we have talked about left ventricle and right ventricle. However, this large data of 68,000 patients, healthy individual says the left atrial reservoir strain is 38 plus minus 3%, and left atrial volume is 24 plus minus 6 ml. So a volume which exceeds 30 ml, 35 ml per meter square is abnormal, and a strain which actually is less than 32% is abnormal. The two are not intricately linked. You can have normal volume and reduced strain, and you can have high volume and normal strain, and both need to be measured to talk about left atrial function in a proper manner. So the very recent study actually just published this week shows that left atrial reservoir strain can predict the occurrence of atrial fibrillation on follow-up in heart failure with preserved ejection fraction. If the left atrial reservoir strain is less than 21%, chances of developing atrial fibrillation next 5 years are more than 50%, and these may be individuals who could benefit from prophylactic anticoagulation therapy. The same longitudinal strain, the global longitudinal strain, reservoir strain of left atrium has been used for assessing the prognosis of HFrEF. Here is the data. And it has been shown that independent of left ventricle global longitudinal strain and left atrial volume index, LA strain provides added incremental value. And worst are those people who have a left atrial global reservoir strain less than 12%. The fact also is that even in other conditions, and here of course is a question of is a patient with CRT, the response can be detected by looking at follow-up longitudinal strain. The LA reservoir strain is also correlates with filling pressures, and hence wherever you have indeterminate diastolic function, you don't know what is the filling pressure in this given individual, you can use global atrial longitudinal strain, and that would provide you a reasonable estimate about pulmonary capillary wedge pressure. And I did say that some atrial diseases can be picked up by global longitudinal strain. Here's one of the papers we published some time back with my colleague, Dr. Madhu Shukla. In arrhythmogenic isolated left atrial cardiomyopathy, the left ventricle strain is normal or maybe supernormal, as shown in this case on the left side, and left atrial reservoir strain is reduced to 27%, again indicating uncoupling of the left ventricle and left atrial strain in isolated atrial cardiomyopathy. And this, of course, 57-year female doctor had a recurrent high ectopic atrial activity. So tips, tricks, and pitfalls. Let us now focus on LV longitudinal strain, which is the prime parameter used in clinical practice. Most vendors, actually the vendors have almost standardized the machines, so the difference is not more than 2% in relative term and less than 10% in absolute term with regard to global longitudinal strain. The data also suggests that the strain, global longitudinal strain, in the mean error is lowest amongst all parameters of echocardiographic examination, including mitral E, E2A, the left ventricle diastolic dimension, and of course the transmitral flow pattern. We also have data to suggest that whichever machine you use, the inter-observer variation of ejection fraction is almost twice compared to that of global longitudinal strain, and hence this should be a preferred method of assessing left ventricle function rather than ejection fraction. But at the moment is complementary and synergistic to ejection fraction. However, the same thing is not true for regional strain, because the data shows large variations in regional strain in various vendors, and the variation is in absolute term 3 to 6% for various regions, and hence if you look at peak strain or end systolic strain or post systolic strain, regional strain can be varying as much as 5%. Actually, the inter-vendor limits of agreement can go as much as plus minus 7.5%, and hence somebody might tell you that the regional strain is 1%, the other machine can tell you 16%. So that is the so big variation. Hence, single segmental strain values should be used with caution. Segmental strain pattern analysis may be more robust alternative pattern, may be more robust rather than absolute values. Longitudinal indices and viability has been studied extensively. Currently, actually, it is suggested that if the longitudinal strain actually is less than 5%, forget the minus sign, then there is a good chance that we are dealing with a non-viable myocardial segment. And here is actually a case used in stress echocardiography. People have used it, but it is not recommended. The British Society of Echocardiography last year came up with guidelines suggesting that strain imaging should not be combined with stress echo because it is not robust and reproducible. But it's just to show on left side a patient with circumflex disease having normal strain of the free wall of the postolateral wall or the infralateral wall actually at rest, and of course stress is markedly reduced. Probably we need to refine this technique more before we can talk about combining stress echo with strain echo. So where do we use strain echo? The strain imaging used for assessing subclinical left and right ventricle function, left atrial function, understanding heart failure, both HFrEF and HFpEF, physiological versus pathological left ventricle hypertrophy, understanding muscle mechanics, understanding dysynchrony, viability and reserve remodeling, predicting fibrosis, monitoring chemotherapy, monitoring heart transplant patients, and of course, following the asymptomatic valvular heart disease patient. So the list is much longer, but just to show some examples, a large study of HFrEF patients showing that mortality actually increases by 15% with every 1% decrease in global longitudinal strain. So you must mention global longitudinal strain along with ejection fraction, more so when ejection fraction is above 35%. Then it has much more incremental value. But if both are severely depressed, then GLS does not provide incremental value over ejection fraction. In HFpEF, it provides incremental value. This is data from echo substudy of TopCat, and it says that in patients with preserved ejection fraction, heart failure, worse GLS, and here it was less than 15.8%, was independently associated with worse outcome. The outcome was twice worse in those who had GLS less than 15.8% with HFpEF. So this also tells us one fact, that there are a good number of people where left ventricle is not involved and still they have heart failure with preserved ejection fraction, emphasizing the fact that HFpEF may be an extra cardiac disease in good number of patients, and please keep that thing in mind. What about the preclinical or subclinical disease? Let me just give you an example. This is a 35-year male on maintenance hemodialysis. The ejection fraction is 52%, but you might say, well, it is okay. It's not too bad. But when you look at the global longitudinal strain, two things, the bullseye map, two things stand out. Patient has definite evidence of heart disease. The global longitudinal strain is 7%, and a big area of the free wall actually has significant amount of fibrosis because that is totally blue. But when you look at the fourth chamber and you look at the motion or thickening, you can't make out that these things are happening. That is the value of global longitudinal strain in detecting subclinical disease and in reclassifying disease. Reclassifying, because suppose this was a patient with diabetes, you would have seen only the right picture, you would say it is a stage A of heart failure, only risk factor present. When you see the picture on the left side, you'll say it is stage B of heart failure, which means there is subclinical disease already present. The greatest advantage which people are thinking of about the longitudinal strain is in following the patient, following cancer patient, following chemotherapy, and sucker data we are still awaiting. But it says that chemotherapeutic cardiotoxicity can be picked up earlier than fall in ejection fraction. You need 10% fall in ejection fraction before you pick up chemotherapeutic toxicity. However, here, a 15% relative decrease in GLS is much more reproducible, robust, and provides data that chemotherapy needs to be, chemotherapy toxicity needs to be kept in mind. And a 3% absolute GLS reduction means you have to take action. If it's absolutely necessary, space it out, reduce the dose, and maybe you have to prevent it altogether. Very recent data, and that is of great interest, is talking about cardiac vulnerability beyond ejection fraction. There are two parameters: extracellular volume, that is detected by CMR, and global longitudinal strain, which is a parameter of contractile apparatus, largely by echo. And both these parameters provide you data about cardiac vulnerability beyond ejection fraction. And both are independent. The interesting thing which you see is the strain to some extent correlates with the ejection fraction. However, extracellular volume does not correlate with global longitudinal strain. So do not think that if the extracellular volume has expanded, that global longitudinal strain would significantly go down. It goes down, definitely, but not in a one-to-one relationship. The data has also suggested that a global longitudinal strain of the left ventricle less than 15% is suggestive of presence of myocardial fibrosis with a sensitivity and specificity close to 85%. And this has been the basis of using global longitudinal strain in asymptomatic valvular heart disease, especially in aortic stenosis, mitral regurgitation, and aortic regurgitation. But you can also use actually longitudinal strain in detecting stable coronary artery disease or chronic coronary syndrome. This is data from Egypt. published in Indian Heart Journal 2 years back by Shamima Mustafa, showing that as the number of the vessels involved increase, the global longitudinal strain falls. From 20%, when you see something closer to less than 15%, multi-vessel disease is likely. So one of the ways of screening for asymptomatic coronary artery disease could be looking at global longitudinal strain, because the Shamima Mustafa and colleagues have shown that global longitudinal strain decreases pari passu with anatomical extent of coronary artery disease. But keep in mind one thing, that there is a relationship between global longitudinal strain and ejection fraction. It is strong, but there is a wide variation. So let me talk about 50% ejection fraction shown in red line, red arrows. With 50% ejection fraction, global longitudinal strain can be as low as 3% and as high as 20%. That is a variation. So at both ends, the global longitudinal strain provides incremental prognostic and diagnostic value in diverse cardiac disorders. Here is actually an asymptomatic valvular heart disease. I was talking to you. Aortic stenosis patient, global longitudinal is 10%. Patient is asymptomatic, severe, and ejection fraction pretty good actually, more than 60%. Would you suggest surgery? Conventional criteria say no, but when you look at global longitudinal strain of 10% and you look at actually the pattern, it suggests a lot of fibrosis already taken place. This may actually still be quite late for doing an AVR in this patient. That is the value of global longitudinal strain. So the data actually of more than 1,000 patients of aortic stenosis, asymptomatic severe aortic stenosis and ejection fraction, more than 50% have said that bad prognosis is indicated if the global longitudinal strain is less than 14.7%, and mortality is 2.5 times more in case the strain values have already fallen below 15%, although sensitivity and specificity of this is modest. Even in patients with severe aortic regurgitation, a longitudinal strain of less than 19% indicates a high mortality. That means people should be operated when the global longitudinal strain has just started falling below 19%. Same thing is probably true of our mitral regurgitation. Mitral regurgitation, anything below 20% would be a great idea to operate these people, because data shows that whether you talk of extracellular volume on CMR or you talk of global longitudinal strain by echo, moment it falls below 20%, patients are going to do very bad after mitral valve replacement. Similar way, if the extracellular volume falls below, goes above 30%, patients are going to behave very badly, indicating need for including global longitudinal strain as a parameter to decide early surgery in asymptomatic valvular heart disease. So in valvular heart disease, in aortic stenosis, the cutoff is around 15%, AR is about 18 to 19%, MR is 20 to 22%, because it is to some extent load dependent. You can make a diagnosis and prognosis patient amyloid because of this, the cherry on top appearance and bullseye map. And this has a good sensitivity and specificity, although cherry on top can occur in diverse disorders. But in amyloid cardiomyopathy, you have to, at least amyloid should come in your mind. Some people have suggested that cherry on top has a sensitivity as much as 93% and specificity as high as 82%. But the important thing is global longitudinal strain correlates with amyloid load. And this is a very recent study actually just published this week, saying that, for example, in this particular patient, you can see good amount of amyloid deposit by cardiac MR. This is a delayed gadolinium enhancement. The contrast-free area is minimal actually in the left ventricle, and the global longitudinal strain is just minus 3.7, indicating very large amyloid load, which could be predicted only, which can be predicted by longitudinal strain. And you don't have to necessarily look at cardiac MR. Of course, both are complementary. This is just, of course, what we are talking about. Heart failure rejection is another thing which has been talked. It has been suggested that a grade 2 or more rejection can be predicted in case global longitudinal strain is 14% or less, with a very high degree of sensitivity and specificity. So these are some of the clinical values of global longitudinal strain. So I took you to, what are the point which I have to tell? There are limitations to speckle tracking. If you have frame rate which is low, it is not a good idea. Tracking quality is low, it's not a very good idea. Through plane motion can occur. Poor feasibility of segmental strain I discussed. Smoothing algorithm to reduce noise. Curvature dependency is another thing which I didn't discuss in detail because there was no time. It's already going to be 1 hour and a region of interest. So finally, strain imaging provides objectivity for LV function, quantification, more information, new information, more physiology, more idea about synchrony and synergy, which we did not talk by because of want of time. And of course, it provides idea about subclinical function. Much more, it is reproducible and robust. At the end, I want to end by saying all we know is still infinitely less than all that remains unknown. Thank you very much. You are muted. Mani, you are muted.
Am I audible?
Yes, now you are audible.
Yeah, it's a brilliant talk by Dr. J C Mohan as usual. Regarding this lecture, he has covered the fundamentals in detail. Clinical application, he has touched almost most of the disease processes in detail. And regarding the valvular heart disease, I will start the question, I will start the ball rolling. Regarding the valvular heart disease, you touched upon the aortic stenosis and mitral regurgitation and aortic regurgitation. Being an Indian citizen, we are more interested in mitral stenosis. What would be the GLS value of the left ventricle in the case of mitral stenosis? Is there any paper or any experience of it?
So we have data. Actually, the global longitudinal strain in mitral stenosis is reduced. We published this data somewhere around 15 years back, Partho being the first author of this paper. I think it's published in the General American Society of Echocardiography. Then in 2014, Shantanu Sen Gupta from India actually published data showing that global longitudinal strain in mitral stenosis is reduced, and it increases following PTMC, and it increases proportional to increase in mitral valve area, suggesting that global longitudinal strain in mitral stenosis is load dependent.
Okay, fine. So now the floor is open for discussion and questions are invited. And the first question is, what is the difference in GLS in ischemic heart disease with AF? Dr. Radha Sharan Prasad.
No, the only thing is you have to use multiple beats to get GLS and it will be less reproducible. But having said that, in ischemic heart disease and atrial fibrillation, the GLS is not going to be very different. Keep in mind one thing, that presence of atrial fibrillation actually indicates advanced left ventricle and or left atrial dysfunction. So strain values will always be lower when AF is present. Much more data has been generated by predicting atrial fibrillation, by looking at left atrial strain, by prognosis. When you talk of prognosis, the atrial strain has to be lowered by 5 degrees in presence of atrial fibrillation compared to sinus rhythm. And of course, in HFpEF, I already showed you the data.
If you have a probe, you can get a single bit information which may be of some sort of useful rather than multiple bit scanning.
Well, I think one of the important things, you can do what you call pattern reading. If single beat you find global longitudinal strain actually is 20%, you are happy that everything is within falling in line. Or if it markedly reduce 5-10%, then also know it is really. But beyond that, you won't get exact values from a single beat. In clinical practice, we do a lot of tricks. The whole idea of trick is to get us somewhere. For publishing paper, you need 5 beat, 10 beat, beats with similar RR intervals. But for clinical practice, we can do a lot of things.
Can I add GLS application in my old machine?
You have to talk to your vendor. You have to talk to your vendor. It is possible in many machines and not possible in many.
Role of strain in viability assessment.
I already said there's a lot of work which has been done, and people have talked about ratio of post-systolic strain to total strain. People have talked about ratio of end systolic strain to peak systolic strain. People are talking about absolute strain values. And closer we are is if the absolute strain values are 5% or less in a segment, chances that is non-viable much more. Harry Rakowski, actually, who is dead, from Canada, published some 10-15 years back data to suggest that in case there is a hollow systolic stretch or hollow systolic positive strain of a segment, that segment is dead.
Is there any way to differentiate ischemic and dilated cardiomyopathy by GLS?
No, there is none. Actually, you can't differentiate. We have seen umpteen number of examples. There is so much of overlap, you can't differentiate the two. However, what you can do is probably try to look for some obstructions in the cornea, coronary vessels. Although it is difficult to image the coronaries, maybe myocardial perfusion imaging can help, and you can detect more with the stress myocardial perfusion imaging. If you find reversible hypoperfusions, maybe that can provide idea about coronary artery disease, but even then, it's not going to be 100%.
Can STE strain be used in the recovery phase of stress echo to predict inducible ischemia rather than peak stress?
Yeah, I think we can use it. There's no reason why we can't use it, because strain has a memory, and memory lasts much longer than the ST changes, and hence it can be. But this would be work in progress. I don't think any society at this moment is recommending it, but it's a good way, actually. I think we should generate more data in this direction.
How to trace Speckle tracking in pseudo-aneurysm in CAD? Dr. Radha Sharan Prasad. Pseudo-aneurysm in CAD.
Pseudo-aneurysm in CAD and true aneurysm, I don't think the GLS can differentiate, but otherwise pseudo-aneurysm and true aneurysm have well-defined criteria which we can use, and in case we are not able to do that, the best thing is to do a CMR. Actually, that tries to differentiate much accurately. Dr. Ramdev Yadav had asked one question of GLS in hypertrophic cardiomyopathy, and I need to answer that question. Hypertrophic cardiomyopathy, GLS is number one, prognostic. Number two, diagnostic. If you see paradoxical strain in interventricular septum or segmental paradoxical strain, that means positive strain in hypertrophied heart, usually it is not as a result of hypertension or amyloidosis. It is as a result of myocardial fiber disarray and hypertrophic cardiomyopathy. And Ted Abraham, who actually moved from Mayo Clinic to this area near Washington, I'm forgetting, actually published a lot of work to show that regional paradoxical strain correlates with myofiber disarray in hypertrophic cardiomyopathy. People have also done studies to show that RV-GLS correlates with prognosis in hypertrophic cardiomyopathy. People have also done studies to say that in a thick wall ventricle, if the global longitudinal strain is 10% or less, it differentiates hypertensive heart disease from hypertrophic cardiomyopathy. These are some of the things I want to say about that. modified less than -15.8. People with reduced longitudinal strain had worse prognosis, meaning thereby there would be good number of people who would have longitudinal strain nearly normal in HFpEF. These people will have good prognosis, because HFpEF is not only a cardiovascular disease, it is an extracardiac disease as well.
By looking at ejection fraction, can you extrapolate or predict what would be the GLS approximately?
Yes, you can do it. In case there is no pressure overload, and in case it is not amyloid, in case it is not hypertrophic cardiomyopathy, in common garden there is a rule of multiplying strain by 3 or 3.5, or dividing the ejection fraction by 3 to get a global longitudinal strain. Rough, very rough.
According to Thomas Marwick group, they have studied and compared to some extent a small study. When the ejection fraction is less than 35, the approximate GLS would be less than 12%. When the ejection fraction is less than 22%, the approximate GLS would be less than 5.9%, according to the Thomas Marwick group. But as you said in your early lecture, in your early point out, there may not be any correlation between the EF and the GLS in some of the instances.
So I actually showed you a study of 4,000 patients where for 50% ejection fraction, GLS could vary from 3 to 20%. I think that should answer the question to some extent.
So as per the coordinator, no more questions posted. So we are at the final step of the program. This is the wrap-up program. Dr. J C Mohan is a well-versed cardiologist and one of the icons in the field of echocardiography. And as I said earlier, his contribution to the IAE is enormous. And today he has talked about the basics of 2D various strains, and especially 2D strain and its applicability to the left ventricle and to some extent the left atrium. And also he touched upon the right ventricular aspect also. So regarding heart failure with reduced ejection fraction is the first marker of assessing LV systolic function. The second marker of assessing LV systolic function is global longitudinal strain. Soon we are going to get the third marker of systolic dysfunction derived from 2D strain, that is global myocardial work index. This is going to be the third marker of LV systolic function, where we incorporate systolic blood pressure to the echocardiographic machine. Machine gives you, the software gives you the pressure strain loop. From the pressure strain loop, we can deduce so many information during systole. Similarly, the future point of diastolic dysfunction will be pressure volume loop derived from 2D strain. Soon we will be getting all this information, interesting informations. With this concluding remark, I conclude this session. Thank you very much, one and all. Thank you.
Thank you. Thank you. Thank you. Thank you.